MACRA Committee. Today's webinar will be recorded. It is for 1 hour, which includes 30 minutes for Q&A. Please feel free to submit questions. Thank you so much for your interest in this webinar. I will now turn it over to Dr. Nicola.
Thank you, Angela. Thank you, everybody, for joining us. We were asked to give this webinar because as we were giving the webinars about registries, we realized there was a significant portion of the membership that would not necessarily have registry capabilities through the first year. There's also been some changes to the first year that's made the law basically much easier to navigate, so we wanted to just inform our members of this. I don't have any disclosures, so I want to start off with this page. These slides will be made available to everyone, but this might be an important slide. You don't have to take notes. We'll put this online. Basically, these are all the resources that you could use to help your smaller rural practice. And these resources are specific for small and rural practices. And also health shortage areas also there's resources for. But basically, you can go to acr.org. We have a MACRA tab where we're producing not only material about registries, but also material for small and rural practices. Medicare has a website now that is quite easy to navigate and is quite helpful, called the qpp.cms.gov, that basically describes the program. It has a couple areas where you can type in what you do and it'll help you pick measures. It's quite a useful website, especially in the early phases of this program. This is probably the most important thing, is that MACRA has, the law itself allocated $100 million in technical assistance over 5 years, so $20 million a year, to specifically to quality improvement organizations and regional extension centers. Many states have these. I know in New Jersey, where I practice, we have one of these. And they are tasked with helping specifically small and rural practices implement MACRA in their practice and implement value-based change. So I suggest every one of you in your state find out who is your quality improvement organization or regional extension centers, and they have technical assistance available for you to help you navigate MACRA and help you hook into a health information exchange and pick measures and do all sorts of things. The other thing that I've found helpful, and this is not just for small and rural practices, I'm in a larger practice, is the Transforming Clinical Practice Initiative. This is actually a third round grant release from the CMS Innovation Center. And basically it's kind of a way to help practices transform by specific paradigms. And again, these quality improvement organizations and regional extension centers are often the holders of these grants in states. And they can come in and help you really design your practice to get ready for value-based care. Additionally, if you're doing it through this pathway, the Transforming Clinical Practice Initiative, you could be eligible for one of the improvement activities. This could satisfy one of the improvement activities for MIPS, which I'll talk about later. And RSCAN is one of the support and alignment networks that helps you transition to value-based care. One of my favorites is the Healthcare Payment Learning Action Network, or Learning Action Network. They're worth following on Twitter. They also have a website that's worth logging on. They do have work groups for small and rural practices and some helpful information there. Just so if you want to know where I got all this information, it's the website down below. It's actually Medicare Small and Rural Practice Fact Sheet, and everything about what I have up in this slide is on there. So I'm going to talk about a final rule today. But I want to give you a little background of what exactly that means. So when a healthcare law such as MACRA passes, which happened in April of 2015, subsequently the regulators need to go back and fill in kind of the rules of the law. And that's what they did. Medicare got the law, and the law was 96 pages. They filled in rules, and the rules ended up being 962 pages of proposed rulemaking. And then that was open for comments, which ACR did through the ACR MACRA committee. And then subsequently a final rule, which answered all the questions, or supposedly answered all the questions that all the stakeholders had, was published in October of this year. The final rule happened to be 2,390 pages, just showing you how many stakeholder comments there actually were about the proposed rule. In fact, there was over 4,000 stakeholders who made comments about this. It's an extremely nuanced piece of legislation and rulemaking, but I will tell you they've made the first year significantly easier. In fact, everybody on this phone call should be able to pass the first year with, at the very least, a neutral adjustment if you will listen to the rest of this call. It's pretty easy. Just so you know, the MACRA rule will be every year. There'll be a proposed rule and a final rule every year. The ACR will be commenting on it and reading these large pieces of documents to make sure that our interests and our members are protected. So this is one misconception about MACRA, is that many people think they don't need to participate. And I'll go through a couple of things where there's very few people who are actually out of this whole piece of legislation, just a very small portion. Most of us on this phone call will be participating in this. So what exactly is MACRA? It's the Medicare Access and Chip Reauthorization Act of 2015. And the very first thing it did was repeal the SGR payment methodology, which was basically mandating draconian cuts to the physician fee schedule every year and required yearly patches. So the most important thing this did was stabilize our fee schedule. The second thing it did is all the current performance programs that we currently deal with, Pqrs, value modifier, meaningful use, it consolidated those performance programs into one performance program called the Merit-Based Incentive Payment System, or MIPS. It cleaned the programs up. It actually made them easier. So if you've been doing those programs or at least aware of them, the programs are actually easier to do under MACRA. And it cleaned up the redundancies and actually lessened the total penalties. So that's important to know, that basically we're doing, MIPS is really just pre-existing performance programs cleaned up. So basically these three performance programs have been implemented over a number of years, going back almost a decade. The first one came in the Tax Relief and Healthcare Act of 2006, and that was a physician quality reporting system. And this is going to serve as a foundation of one of the categories in MIPS. Pqrs was basically a program where you just had to report a quality measure associated with an encounter that you had. You didn't actually have to perform the quality measure, you just had to report it. So it was a fairly simple nonsense program that it started with negative, positive adjustments if you did it, and then it eventually migrated into negative adjustments over a few years. The second part of the MIPS will be a permutation of the Meaningful Use Program, which came out of the American Recovery and Reinvestment Act of 2009 in the Health Information and Technology section of this act, that established the Certified Electronic Health Records incentive program that would incentivize physicians to adopt certified electronic health records in the country. There is no longer a positive incentive just for participating in this program. It'll be merged into MIPS, and I'll talk about it a little bit later. Also, under the HITECH Act and under the Meaningful Use Program, radiologists had an automatic exemption based on your Pqrs specialty classification. That changes a bit. The exemptions change a bit, and I'll talk about that a little bit later. Finally, the third program that's important in the MIPS paradigm is a value modifier program. This actually came from the Affordable Care Act. It's one of the lesser known mandates of the Affordable Care Act. It did a couple things. One is it looked at how much cost you caused per episode or per specific diagnosis code that you were submitting, and compared you to physicians doing something similar. There was a couple broad cost measures. There's also broader cost measures about your population in your region that they held you accountable for. And then finally, probably the most important thing in there was a performance measure on how well you did on your Pqrs measures. If you remember, I just described Pqrs as just a reporting program. Well, Value Modifier gave teeth to that reporting program and actually required you to perform on the measure, not just report it. So there we have it, the foundation for MIPS. That's one of the payment paradigms in MACRA, and it's basically built off those three performance programs that all of us either should have some familiarity with or we're doing. MACRA is slightly more complex than this. It has another limb called the Alternative Payment Model limb that I'm just assuming there's not a lot of people on the call going into that limb, so I'm going to avoid talking about this during this lecture, but I've talked about it in several past webinars. I will just briefly talk about the terminology, because this entire program has been renamed the Quality Payment Program, or QPP, so you won't necessarily hear MACRA much, but QPP. APMs, it turns out, was a much more narrow category than we thought they were going to be. In fact, there's a new term called advanced APMs, because not all APMs are advanced APMs. In fact, a number of alternative payment models, including the Bundled Payment for Care Improvement Initiative started by Medicare, did not meet the advanced APM criteria and ended up somewhere in between MIPS and APMs. What this did is that there's a lot more than just those who participate in APMs and those who participate in MIPS. In the QPP, there's 5 different types of providers, and I'm not going to be too deeply except for a few. There is a MIPS, or a qualified participant advanced APMs. These are people who are in the correct model of APMs. They also have a correct threshold of participation. And basically what that means is that they're eligible for significant upside benefits established under MACRA. There are also people who are in the correct model of APMs, but have a lesser threshold of patients or dollars that are in that APM. These people are called partial QP providers. And they're not eligible for so much of the upside of APMs or the APM pathway, but they're immune from MIPS. They could be immune from MIPS if they chose to be. It's their choice. And MIPS is particularly more toxic than the APM limb. There are also providers that are in the wrong APM model, or they're in the right APM model but the wrong thresholds. And these folks unfortunately have to compete in MIPS, but they're given favorable status. Then there's MIPS eligible clinicians, which is going to be most of us on the phone that are receiving fee-for-service Medicare and basically tied to these value programs of MIPS. And finally, there's a fifth that's very rarely talked about because it's a very small percentage of people, and that are those who aren't even eligible for QPP. And it's mainly because they have a low volume threshold. I'm going to talk about these two in greater detail. The other ones I will not be talking about on this webinar. Let's start off with not eligible for QPP, low volume threshold providers. There's a very strict definition in the rule. And basically, if you have, as an individual level or group level, if you have $30,000 in Medicare expense, if you bill Part B more than $30,000, or you have 100 Medicare patients, you have to have below these numbers, and you would no longer you wouldn't even be in MIPS. If you're above these numbers, you're in MIPS. And that's basically the cutoff. So very few people will probably meet this low volume threshold. These people would just be in regular fee-for-service Medicare and not have to report to MIPS. So most of us are probably going to be MIPS eligible clinicians, or ECs. So let's dive into this a little bit more. The merit-based incentive payment system. I've already laid it out for you that the physician quality reporting system, value modifier, and meaningful use, which you see here on the left, are going to be the foundation of this program. The specific subsets of this program have changed names. For example, physician quality reporting system becomes quality under MIPS. Value modifier becomes cost. Meaningful use becomes advancing care information. And the legislators did add a new activity called improvement activities, which we'll dive into a little bit later. There are some substantive changes between these programs. I talked about how reporting rate was a Pqrs phenomenon and performance rate was a value modifier phenomenon. Also in value modifier were claims cost of how much you were billing per specific indication. Well, what happens in MIPS is that both reporting rate and performance rate move up into quality. So to do well in quality, you actually have to not only report the minimum threshold, but you actually have to do well on the measure. And I'll talk about how they're going to benchmark us in a little bit. Cost no longer has reporting requirements, but they still do calculate cost measures based on the bills you submit. So what happens is each of these 4 new categories, which you'll see on the right here, will be scored. They'll be added together to form 100 points. And each of us will be given a score based on how we did in each of the performance categories of somewhere between 0 and 100. And that score will be calculated off a performance year. And then how well you did will determine adjustments during a adjustment year, which happens to be 2 years after the performance year. And what happens during the adjustment year is that your reputation is at stake because your final score will go online, as will measures and how you did on them. And you will have some income at risk. It can be positive adjustment to your income or a negative adjustment. So let's talk about how each of these categories make up the final score. Here you have the 4 different performance categories reviewed. I'm currently talking about patient-facing doctors, and I'll dive into this a little bit later. And this is for the 2019 adjustment year. So the performance year is traditionally 2 years before that. So the first performance year would be 2017, adjustment year 2019. Medicare has said they don't want anyone responsible for costs the first year. This will be phased in the 2nd and 3rd year, but for the first year, no one, it doesn't matter if you're patient-facing or non-patient-facing, will be subject to cost adjustments. However, Medicare will collect cost data on you and give you feedback on it. So what happens is all of the cost is redistributed to the quality, and to calculate 100 points on the scale, You get 60 in quality, 25 in advancing care information, and 15 in improvement activities. Now, if you have to do 2 to 4 activities if you're patient-facing, unless you're one of these special scoring considerations. If you're in a small practice defined as 15 or fewer, and you're a MIPS-eligible clinician, you're in a rural practice defined by your zip code, or health professional shortage area. If that's the case and you're patient-facing, the only change is that the improvement activities go to 1 to 2. You have to do 1 to 2 activities, depending on how the activities are weighted, which we'll show a little bit later. Well, there are also special scoring considerations for doctors they labeled as non-patient facing, and that happens to be a large portion of radiologists and pathologists, but not all. And what happens to non-patient facing doctors for the first adjustment year of 2019, first performance year of 2017, is that we also don't have to do cost. But to be very clear, cost will also be phased in for us in year 2 and 3. But we do not have to do advancing care information if you meet the non-patient facing definition. And that should be the case for some time. Although Medicare has asked us to create measures in advancing care information that we could do, they're currently not available. So in the foreseeable future, we will not be doing advancing care information. But cost, we will be accountable after the first performance year. What happens is, for the breakdown of the 100-point scale, is almost everything goes into quality for the first performance year of 2017, the 85 points, and 15 go into improvement activities. And for non-patient facing doctors, you only have to do 1 to 2 activities. And that's basically the breakup. Medicare has defined patient-facing clinicians differently than it has in the past. In the past, it's often used your Pqrs specialty classification code, like in meaningful use, where interventional radiologists and diagnostic radiologists were exempt just because of their Pqrs specialty classification. That is not the case under MACRA. In fact, Medicare originally proposed that they would look to see how many patient-facing CPT codes you build in a year and determine if you were a patient-facing doctor. They originally proposed 25 of these patient-facing codes, either for a group or an individual, and we certainly pushed back on our rule letter, and Medicare ended up going to 100 for the final rule. The one problem is we have no idea what a patient-facing code is. Even to this date, we suspect at the end of December, which is we know is alarmingly close to the performance year, but there's not much we can do to motivate Medicare any further. But it could include E&M codes, 10 and 90-day surgical codes, or 0-day global codes. But just to remember, these are 100 Medicare patients. So if you do a lot of paracentesis, which is a 0-day global surgical code, you'd have to do 100 in a year in order to be 100 of Medicare patients in a year in order to be called a patient-facing doctor. So there is some leeway in the fact that it's just Medicare patients, but still 100, I suspect some doctors who do a large number of 0-day global surgical codes, if that's included in the definition, such as breast doctors and those who do lots of paracenteses and PICC lines, could end up being patient-facing. On the group level, Medicare no longer capped it at 100. What they allowed is, as long as 75% of the group looked at as individuals was below 100 patient-facing codes, then the entire group can be considered non-patient-facing. So they greatly expanded the group definition, which was very helpful for us. Again, this program's first adjustment year is January 1st, 2019. Of course, they need data on us well before then, and that's going to be collected in January of 2017. What happens is, once they get data on you and they give you a total score somewhere between 0 and 100, Medicare's supposed to pick a performance threshold, which should be a mean or median of everyone, all specialties, performance final scores added together, and somewhere you'll end up somewhere on this scale. If you're below it, you would get, for the first year, a minus or positive 4% adjustment somewhere along the line, anywhere from 0 to -4 or 0 to +4 adjustment. It's an adjustment factor. It's actually not an adjustment to your income. And what that would look like is this, is because I don't want to confuse you, because an adjustment factor is not an adjustment to your income. They're different things. The adjustment factor is 4%, but that then has to be multiplied by a scaling factor, which is a factor that accounts for budget neutrality. To simplify this, what this means is the downside risk is still -4%, but the upside benefit could be 4 times 3, which is 12% for the first year. Medicare allowed the program just to freely pick its own performance threshold based on mean or median, but Medicare decided not to do that. In fact, they realized that this alarmed much of the country, that so many people would potentially get a -4% adjustment factor and adjustment to their income. There was a lot of pushback that the program was coming too fast. So Medicare actually made the first year very easy, and this is what we're going to discuss here. And this is how easy it is. All you have to do is submit one quality measure with one patient that you've performed positively on for the entire year, and you as an eligible clinician have passed the program without any negative adjustment. It's that easy. Or you could submit one improvement activity for yourself. That is it. So everyone should pass it, because all you have to do is have one positive performance rate on one quality measure or one improvement activity, and you've passed the program for the entire year. You literally only have to submit one patient for the quality measure. That's it. But remember, it has to be done for every doctor in the group individual, the group, if you report as a group. The other ways you could participate in the program is you could try reporting for somewhere around 90 days and possibly get a positive adjustment. You could report for a full year and possibly get a positive adjustment, or you can just say, I'm not going to report at all, or you could be an advanced APM. Those are basically the ways you're going to try to accomplish the program the first year. Now, because Medicare has artificially prevented most people from receiving a negative adjustment, essentially what they've done is set the performance threshold at 3, not at the median or mean, but at 3. That means you need 3 out of 100 points to either get a neutral or positive adjustment in this program. The only way to get a negative adjustment is completely just ignore the entire thing, and you will automatically get a -4% adjustment factor, which is actually a -4% adjustment to your income in this specific case. But because they've artificially chosen such a large performance rate, the scaling factor is well less than 1, and even the people who perform excellent in this program will see nowhere near a positive 4% adjustment in their income. They'll probably see somewhere no greater than 1 or 2% positive adjustment, even if they got 100 out of 100 points. And that's because this program's budget neutral, and in order to pay the winners, you have to take from the losers. And if you're preventing most people from losing, you have very little money to distribute to the positive, those who have done well on the program. Now, that's just for the first year. I suspect the second year will be more competitive. Now, this is the ways you can submit data to this program. You can submit as an individual, or you can submit as a group by taxpayer ID. Remember, a group is defined as 2 or more MIPS eligible clinicians. That's it. All you need is 2, and you could potentially submit as a group. There's a lot of different mechanisms and ways to submit, either as a group or individual, but in all honesty, for radiology, this is all you have. As an individual, you can report through a qualified clinical data registry, qualified registry, which are different things, or claims, which is probably what most people have been doing, where your billing company submits a bill and they can put specific codes in the bill to say that you've done Pqrs or MIPS when it evolves to MIPS. Or you can report as a group, which you only have 2 options. There is no claims option in group reporting. So I want to go through what you have to do if you're somebody who fills out your own bills in order to properly comply with this first year program, the first year of this program. Because remember, you only have to literally fill out one bill correctly, and you as an individual in claims is protected from the whole year and from any negative adjustment. So this is your CMS 1500 form, and I want to highlight this box because this is where all the action is going to go on for MIPS. Let's blow this up, and by the way, this is Medicare has this. This is from Medicare themselves. So here's the most important things to do. First is you have to put an Icd-10 code for the reason the study was done that you're billing, and obviously you would put Icd-10 is now 0 for the Icd-10 indicator. Then what you're going to do is you're going to fill out the dates of your encounter and the proper CPT code on this line, plus the diagnosis pointer, which is going to point to what this CPT code is associated with what Icd-10 code. So in this case, A, which is line A. Then you're going to submit the charges and the individual NPI number of the doctor who had this encounter. The next line is where you're going to start filling out. This is where you currently would fill out your Pqrs information and where you will fill out your MIPS quality information. You're going to fill out the date of service, which is going to be the same as the CPT code 1 encounter. Then you're going to fill out something called a quality data code or CPT type 2 code. This is not the same as a CPT type 1 code, but I'll tell you where you find these in a second. These codes are specific for performance on a specific Pqrs or MIPS measure. And they are specific numbers on whether you met the measure, did not meet the measure, or were excluded. And I'll show you where to find these codes in a second. You also have to point to a diagnosis code, and it has to be the same as your CPT code. You have to bill a nominal charge of 1 cent, although the beneficiary is not responsible for this. It's just a placeholder. And then you'll also put in the clinician's NPI number. There may be more than one performance measure associated with each CPT code, so you have to be aware of that. The last thing you're going to do is either, if you're billing as a group, you fill out the group MPI number, or the individual, you fill out the individual MPI number. So this is how basically it all happens. Now, where do you get the CPT2 code, or also called the QDC code? Well, if you look up the measure you're reporting, especially on the ACR website, they have a whole measures tab, you'll find a document that will tell you exactly what you have to do for each of these codes. So in the case of measure 145, which is radiology exposure time, the fluoro time, it gives you a list of all CPT codes that are associated with this measure. So if you bill one of these CPT codes, then you need to fill out a Pqrs or MIPS measure. And again, you only have to do this once in order to pass it the first year. Within this document, if you dig a little deeper, it will tell you the performance not met QDC code or the performance met code. And these are the codes that you would fill in this box right here. So if you met the performance, you would use G9500. If you did not meet it, it would be G9501. Now remember, you have to meet the performance on one patient. So for one patient, you have to, at least if you were using this measure, you have to use G9500 in order to fulfill the first year requirement. If you did G9501, you technically did not fulfill what they need. So let's dig a little bit deeper in case you want to perform fully in this program so you understand all the rules. In the quality section, it's a little more than just submitting one measure if you wanted to completely perform. But if you submit one measure, you'll be fine for a neutral adjustment. If you want to fully perform in the program and get ready for years 2, 3, and 4 and onwards, you would technically have to submit 6 quality measures, and one of them should include an outcome measure if an outcome measure is available. What happens in this program is if you're using claims-based reporting, you need to report at least 50% of your patients for that, for when the measure applies, for just Medicare. But if you're using Registry or Qualified Clinical Data Registry, you have to report at least 50% of all your patients. Each measure is worth 10 points, and you're scored on a decile ranking based off benchmark years. So for 2017 performance year, the benchmarks will be established in 2015. Let's say the benchmarks 85% of people performed on a measure. That would probably be about a 5 out of 10 in deciles. So if you got 85 out of 100 times you reported the measure and met the criteria, you would get a 5 out of 10 in that measure, and you'd have to do 5 other measures, and they'd be added up, and that would be your sub-score in quality. I do want to point out a 7th measure that should not apply to radiologists, but occasionally it does, and it has to do with a mistake in your supplier type. There's a 7th measure that should not be attributed to radiologists called all-cause hospital readmission. If this is attributed to you, it's very likely you may have NPs or PAs in your practice, possibly billing under your TIN, and it's possible that your supplier type is group practice or clinic, and you should switch that to other or radiology, and that should prevent this measure from applying to you. That same comment that I just made also applies to several cost measures, so it's important to check your supplier type to make sure you're correct. Now, in all actuality, in the future, claims is really not going to be a great way to report. So although it's going to be around for a number of years, I do suggest migrating out of claims. There's some disadvantages of being in it, and Medicare does want people on paper. They don't want people paper reporting. They want you electronic reporting. Currently, we don't have the ability to EHR report. We will probably in the near future. I do recommend trying to submit one of these ways. EHR reporting, again, will be in the future, not anything immediately, but I do recommend trying to get into a QCDR qualified registry. And because the first year is so easy, you have time. One of the reasons I suggest getting into one of those measures is because if you use one of those other ways of reporting, you can submit across all the performance categories using the same mechanism. But if you use claims, you'll only be able to submit quality, and you'll have to figure out if you're in advancing care information, which mechanism you're going to do. You also have to figure out how you're going to do your improvement activities. So you could have multiple different mechanisms if you use claims. This, using QCDR or registry or EHR just makes it a little bit simpler. Again, costs, there's no reporting requirements. Again, I want to just review QCDR because I think it's the most powerful. What that is our registries, the National Radiology Data Registries. There's a lot of measures that Medicare will accept as quality measures. And I've given this in many other webinars just to show you one of the reasons it's so powerful. For me, under one of my taxpayer IDs, I only have 5 measures and claims I could submit. One of the other taxpayer IDs, I only have 4. Remember, every taxpayer ID, you have to submit this program independent. So you're a different doctor in every taxpayer ID. Now, if I went to a qualified registry, those measures exponentially grow, so I could easily find 6. If I went to QCDR, the measures just blow up, and there's a lot more measures to pick from. Just so you know, they're color-coded because I'm not going to go into details about this, but the green measures tend to be worth more. There's some bonus points opportunities that I go into in other webinars that I'm not going to go into today. So you can see in the QCDR mechanism, there's a lot more ways to get bonus points. Also, QCDR gives you more frequent feedback. The feedback reports, if you do claims, are called QRURs, Quality and Resource Use Report. Actually, you can get this kind of feedback report no matter how you submit, but this is the only way you'll get it through claims. They only come often too late. For example, this is my feedback report for mid-2015. Yet it came April 20th, 2016, with the performance year was already over, so the feedback didn't really help me. If you use a registry, the feedback reports come quarterly, and they can be very useful. I'm not going to do costs because it doesn't matter the first year. Advancing care information, I just want to make one point here. There's a couple ways to be excluded from this category. I mentioned one earlier. That's if you meet the non-patient facing designation. If you do not meet that as an individual or a group, there's a second way that you could potentially be excluded from this category, and that's being called hospital-based. You could be a private practice who staff a hospital, and as long as 75% of your business comes from place of service codes 21, 22, or 23, which is basically ER, inpatient, outpatient, campus, hospital. If 75% of your business comes from that location, you can be deemed hospital-based and be excluded from advancing care information. So even though I think a large portion of radiologists will be excluded from advancing care information by being deemed non-patient facing, another large portion will also be deemed out of this program because of the hospital-based definition. If you did have to do it, it's somewhat complex. I do think it's hard for radiologists to perform. We are working with Medicare to get denominator exclusions like there were in meaningful use, but I don't want to go through this because it's a fairly complex topic that I think most people on this call should be out of this category. And finally, the last category is improvement activities. We all will be doing this. First year, you could skip it because if you only wanted a neutral adjustment, you could just submit one measure, and it could be an improvement activity measure or a quality measure. But if you wanted to completely dive into this, you could try improvement activities the first year. There's 9 broad categories with more than 90 activities. On the right is where you're going to find most of us, the non-patient facing physicians. This is also where the small and rural practice and health shortage area physicians are going to be. You're either going to do 1 high value activity or 2 medium value activities. The activities are variable. If you use registries, there's at least 4 or 5 activities you can do. If you do RScan, which is one of our TCPI initiatives, it's a full value activity and will give you complete, it will completely satisfy this criteria. So there's a number of activities that you'll have to review. We are working at the college to try to find a list for doctors to do. We would have some type of shell of a list published probably in the next couple months. this category, even if you did try to go into MIPS the whole year, it still only is a 90-day reporting period, so you would still only have to do this for 90 days. So if you wanted to report for a full year, you could hold off. You could report a full year for quality measure and just do this for 90 days. So we have some time to get those activities out to you. We've been working on several commissions in that with Medicare to figure out which ones we definitely can do. So that's the MACRA basics. I hope I didn't confuse anyone. I think the take-home points are that most of us are going to be doing this. Most of us were already doing this if you did the Pqrs program. You can continue to use claims-based reporting, and the first year is extremely easy. And everybody on this call should hopefully, at least at the very least, get nothing worse than a neutral adjustment. So I'll open it up now for questions, and I guess we can either do them over the phone or we can type them in.
If you have a question, please go ahead and use the questions tab on the program here. If you do not have that, you can send a message or raise your hand and I will try to get to you. Greg, can you see the questions? I assigned one to you.
I see one says, have we started? Let me see. I probably have to scroll down.
Okay.
Let's see.
And this is Angela. Just a quick clarification. So in terms of participation in 2017, you have really any time from January to October to participate in 2017. You don't have to start on January 1st of 2017.
Yeah, that's correct, Angela. Thanks for that clarification. Just anytime, sometime between January and October, you have to perform on one measure to get a neutral adjustment. So that's correct. Or do a 90-day reporting period, or if you're going to do full year, you would have to start January. So
Are you able to see the question or no?
It says yes, the session will be recorded, right? That one?
Okay. No, there should be, I can read it. What happens if you're hospital-based but ends up also being deemed patient-facing? Then do you have to do advancing care objectives?
No, as long as you meet the hospital-based definition, even if you're patient-facing, you will be out of advancing care information.
Okay. And then hard to come up with outcomes in radiology. Any suggestions?
Well, the registry has a lot of outcomes, so you won't be able to do it in claims, but you can pick other high priority areas based on the NQS domain that can substitute for outcomes. So there's a list, and you can look next to the on the ACR website. They have a list, and they can tell you if they're high priority, and that can replace the outcomes measure. Think like patient safety is high priority, so some of the patient safety measures could be used. For example, I think fluoro time, if I recall correctly. But if you really want outcomes measures, you need to move over to the registry.
And this is Judy Burleson. Also, there are several interventional radiology measures that are outcome measures that can be reported through claims and/or a qualified registry.
Sorry about that. I was just speaking to diagnostic, but you're right.
Okay. Next question: does the ACR accreditation help with MACRA for providers?
No, it doesn't. Doesn't help. However, we're still looking at whether the Diagnostic Imaging Center of Excellence Award counts as an improvement activity. We're still trying to clarify that. So if you went further and got the Diagnostic Imaging Center of Excellence, if you're a recipient of that, it's possible that you can get an improvement activity for that.
Okay. Do you know when the latest PQRS benchmarks will be released?
The 2015 benchmarks are what matter for us, and as far as I know, they might have released them, but they have not put them in deciles, so I don't know how helpful they are. Is that correct, Judy? That I haven't seen them in deciles yet. Have you?
That's correct. Haven't seen them in any form yet, and it will likely be at the beginning of the year.
Yeah, so probably not too long now.
Okay. It was my understanding that IDTFs were excluded from PQRS. Is there an exclusion from MIPS for IDTFs?
Yes. they're basically excluded, right, Judy? That was my take on it.
In effect, they are. They are considered eligible clinicians who are not able to report.
Medicare did make they made a statement in the rule that they would look for mechanisms in the future, but initially there's no mechanism for them to establish accountability in that case.
Right.
We have several folks asking about the slides. We will get the slides posted to the website within the next few days, and we'll send an email to the attendees with a link to that. Next question, how or when do we submit our data to CMS? If we elect to report for an entire year, are we actually reporting in 2018, or do we report throughout the year?
So it depends what reporting mechanism if you use. So if you use claims, you would be reporting every time you submit a bill. So that's real time. And it's one of the negatives of reporting by claims is that you pretty much have to submit all the time. If you use the registries, you really don't have to submit anything to Medicare until after the performance year is over. Usually for our registry, the NRDR, QCDR, usually by early February you need all your data in of a month after the performance year has ended. And then I think the QCR submits to Medicare sometime in March. So there's more flexibility if you use a registry.
That's correct, but I'll just add that if you're using a QCDR or even a qualified registry, if you submit your data to the registry throughout the year, then you will get more robust feedback reports on a quarterly basis, as Greg mentioned.
Yeah, and again, that if you just did it in all one lump sum, you would miss out on one of the benefits I showed you of a registry, and it is those feedback reports. So I'm a registry user. I try to submit monthly, but it's not always that way. But monthly would be the most ideal for I think most people. And again, that wouldn't go to Medicare. It just goes to the American College of Radiology. And at the end of the year, you can help hand select the measures you specifically want to submit. So the other power of registries, which I go through in my other webinars, but I wanted to concentrate on claims-based in this one. But if you want to see the advanced techniques of registry reporting, I suggest you look at another webinar I've recorded probably about 3 or 4 weeks ago. That's a longer version.
And that webinar is posted on the ACR web pages under the Be MACRA Ready tab.
Okay, next question. Should you be selective about which measures you submit? Is there a benefit in only submitting measures where you are performing better?
So, it depends on how much you trust Medicare. So Medicare stated in the final rule that they will calculate the highest final score they can get on you, and they have no problem with you submitting more than the required measures, and they would basically figure out which ones gave you the highest score. So I think that's a nice gesture from Medicare. I'm not sure how long they'll continue to do that, but for the first year, it should not matter how you've performed on a measure. You could probably submit them all as long as you hit the minimum requirement, and they'll calculate your highest final score. I'm somebody who personally likes to control my measures a little more than that, and so I probably would hand select 7 or 8 instead of I collect about 30 with the registries. I'd probably collect 7 or 8 to send. But again, you don't have to. Medicare will calculate the highest final score.
And one benefit of submitting more than the required 6 is if the additional measures that you submit are considered high priority, then you would get the bonus points for those even though the measure isn't scored.
Next question, is there going to be a list of quality measures applicable to radiology practices specifically?
There's not only on our website, but also in the Medicare final rule. I think it's Table E, I want to say. Table E in the final rule is specialty-specific measures. I think we're Table E number 21, specialty number 21. I think all the measures are right there. Though now, not all the measures. I have to be careful. There are measures that can be claims or traditional registry submission. QCDR measures are not talked about in the final rule. They're basically under the purview of the QCDR. So there are a lot more measures that can be submitted that are mentioned in the rule, and you can also find those on the ACR website.
Okay. When will the IR registry be operational, and how can we know the measures available to get started on January 1 for quality measures?
I think I typed that question in, wasn't it? Didn't I just type that question in?
That should be available early 2017, the first quarter. Many of the measures that will be included in the IR registry are will be MIPS measures in 2017. So there are many that are existing measures. There will be several that aren't included as MIPS measures that will be available for reporting. And the best thing to do at this point, if you're interested in the IR registry, is to visit the SIR, Society for Interventional Radiology website for their structured report template information, because that will support submission of data to the ACR, SIR Interventional Radiology Registry that will minimize the burden on data collection and submission.
Just one clarification of what a MIPS measure is versus a non-MIPS measure. Both MIPS measures and non-MIPS measures could be reported to Medicare for quality in MIPS. They count the same less but non-MIPS measures are measures that are under the purview of the QCDR and within NRDR, and you can't find in the rule, but still are available for submission. And MIPS measures are measures that have been qualified and are in the rule. But regardless, you could submit. They're pretty equal. So I just don't want there to be confusion of what a non-MIPS measure is.
Next question, does the adjustment apply to the professional component only or to the global?
It's a global.
Are PAs and APRNs excluded from the MACRA reporting?
PAs are not, right, Judy? I think PAs are in it.
Correct. That they are included. And what was the second one? PAs and what?
APRNs. APRNs.
Advanced practitioner nurses, they're in it
Oh,
too.
RNs are also included.
Okay. Please clarify that if you submit one claim, you are good for adjustments in 2019.
Yes, that's clarified. That is correct. For the adjustment in 2019, you will be neutral if you fill out your claims correctly and that you positively performed on the measure, unless it's an inverse measure and you've met the proper inverse measure criteria. So if basically if you've performed properly on the measure, you will avoid any adjustment, and literally it's one patient. That's it.
Meeting the meeting the 6 measure requirement, and for full reporting the 50% of cases, but for avoiding the penalty in 2019 based on 2017, it's submitting some data.
Yeah, they've made the first year all over the place, but you can try to get the 6 measures, but again, all you really have to do to get a neutral adjustment is one measure, one patient per doctor.
What was said about the hospital readmissions, what about the supplier type?
Supplier type should not be clinic or group practice, and it should be switched to other and radiology. And that's important also in the cost paradigm, but cost doesn't apply the first year, but there are several measures that we have heard radiology groups being attributed in the cost category, and that came out through speaking with CMS. I don't know if we've had any follow-up clarification on that, Judy, but I know that was something we discussed a while back.
We have not as of yet, but that was information provided by the QualityNet help desk.
If you are non-patient facing but hospital-based, do you have to report ACI?
No. In fact, you'd have a double exclusion.
You don't have to do it twice.
Yeah.
To your knowledge, when do quality Pqrs require performance and not just participation? We have been participating since 2000, but focusing so much actual, including for time, for example. When did this change?
It changed under the value modifier in the Affordable Care Act. However, that's been phased in. So the first adjustment for groups under 100, because of the value modifier performance rate, is 2017, meaning 2015 is the first performance year where you had to do well on a Pqrs measure. Right, Judy? I think that's right. That's
2015 is the first performance,
I think the performance
year
year
for groups under 10.
Yeah, for 2017. Or was
groups
it
of 10 or less?
What's that?
For groups of 10 or less, 2015 is the first year where performance.
Correct, yeah, for groups 10 or less, and then a group from 10 to 99, the first performance year was 2004.
Right.
So yeah, that would have, those years have already passed. So if you did poorly, you're going to be getting a negative student.
Next question, are you considered patient-facing only if you bill E&M codes?
We don't know that. All we know is that you have to have 100 encounter codes deemed patient-facing. It could be, for certainly E&M, if you do 100 E&M, you're going to be patient-facing. But I don't know about 0-day global or 10 or 90-day global codes yet. We do not know that.
We likely won't know that until the first of the year.
Okay. Someone is asking if we will be posting the Q&A. The webinar is being recorded, so we will post a link to the recording of the webinar on the website. Next question, my hospital global bills for my small group and we have no control over claims filed. How do we use QCDR step by step?
Hospital bills for the global? Well, they're still going to be liable for it. They'll be liable, they're billing Part B. So I would talk to them and let them know that their payments are liable, and that hopefully they would get your support for using their equipment to submit quality measures, or at least get quality measures from their EHR, because they certainly don't want to lose money on their global.
Next question, the 75% of business includes Medicare charges only, correct?
Yes, for ACI, for the determination of hospital-based, it's Medicare.
If we, as radiologists, have clinics besides hospitals, do we report any of those clinic patients in our current EHR?
It depends on your taxpayer ID structure and what the definition of clinic is. I'm not sure what that means. Is this somebody who sees patients in a clinic? Are they different taxpayer IDs? It's very likely those clinics are going to have to submit data as well, unless they're under a tax ID where the overwhelming majority is from an entity that can submit quality measures and you can meet the 50% reporting threshold, then you could ignore those clinics. But I will tell you, Medicare proposed a 90% reporting threshold, and we moved it down to 50. So if they go up to 70 or 80 or 90% in subsequent years, those clinics would likely dilute your ability to submit in the quality, and eventually they probably would have to submit measures. So it just depends on how complex the taxpayer ID structure is.
Okay. Will Medicare Advantage patients be counted in determining whether a physician is patient-facing?
No, not to my knowledge. I think Medicare Advantage is pretty much out of this program, including the dollars spent on Medicare Advantage. And Medicaid, by the way. Medicaid's out too.
Okay. What determines if you are patient-facing? We have IRADs. Are they patient-facing?
They may be. I don't know. They have to have 100 or more, over 100 patient-facing encounters with Medicare patients in a calendar year during the determination period, which is a 2-year determination period that includes the 2-year prior and a part of the year prior in the performance year. So if they fall into patient-facing during that determination period, they would be patient-facing. Again, it's 100 encounters, but we don't know what type of encounters. We expect the definition of encounters to be sometime at the very end of this month or early in January. And again, it's certainly going to include E&M. So if they have 100 E&Ms in a year already, I can almost guarantee they're going to be patient-facing. Whether 0-day global or 90 and 10-day global count, I don't know yet.
Okay. Last question that we have time for is considered a eligible improvement activity.
Well, I think if you did it, so basically my interpretation improvement activities, and that's what it is, an interpretation, because we don't have a lot of guidance on these, is that if you do an activity that's new to your practice and that you're really implementing change, then it counts. But does it count the next year? I doubt it counts the next year. So I think you know, for example, that there's a 24/7 coverage improvement activity. I think if you do something to if you have 24/7 coverage and you improve it for the year, add subspecialty care, that would probably be an improvement activity for that year. I don't think it would be an improvement activity for the next year unless you made additional improvements. So I think this is supposed to be an evolving category. Medicare also talks about it being scored in the future. Right now it's just an attestation, did you do it or not? But in the future it'll be scored. So I don't think you'll be able to score RADPIR over and over again. So possibly the first year you go away, I'm not really recommending it, but I think it really has to be something that evolves with your practice and makes your practice better.
And it's not just necessarily participating in RADPIR or, for example, some of the improvement activities are using participating in a QCDR for this or that. It has to be that participation, for the way most of the improvement activities read, is that that participation has to be used to develop a plan for and implement some improvements.
Yes.
Okay. Angela, did you have closing remarks?
No, just thank you all for participating on today's webinar, and like Katie indicated, we will send you the recorded version of the webinar.
If we did not get to your questions, we are running a report of the questions, so we'll try to get to those via email in the next few days.
All right, thank you everybody for joining us.
Thank you.
Thank you.